All right, Frank, take it away.
All right, hi everyone. My name is Frank Lee. I'm the current fellow, spine fellow at Union Memorial Hospital. So today's talk will be on thoracolumbar trauma, focusing on burst fractures and chance fractures, and just going through the whole gambit of classification systems for them, how the mechanism of injury occurs, and the treatment for them.
Excellent.
Okay. So I have some in-training exam questions that we commonly saw throughout residency. So I included some of these in this talk just to kind of get you thinking. And I pulled most of these from the OrthoBullets website.
Okay.
So for this first patient, it's a 56-year-old woman. She sustained the fracture shown in the imaging shown there, and she was in a motor vehicle accident. So this question is asking, what's the mechanism that's most likely responsible for this injury?
So I thought this could be maybe a flexion compression fracture, but I guess because there's no distraction here,
Yeah.
they don't think so. So definitely not extension. Because if it was an extension, this would have gone backwards, posteriorly compressed.
Mm-hmm.
Flexion distraction, this would have been distracted.
Right, yeah.
And I'm not sure what a vertical shear would look like.
I'm not really sure what that would mean in the spine either.
Yeah. So.
Yeah, right answer here would be an axial loading injury, where the whole vertebral body is under load and then just fails, turns into a burst fracture. So this is a great picture. Yeah, I appreciate you finding this, showing the fulcrum where this injury happens, and then a lot of times you get the flexion component, and then you get the tension component on the posterior ligamentous complex in the back, and then that causes that compression wedge fracture you see in a lot of vertebral compression fractures. Neutral is more of that axial loading that we probably just saw. And you can also get, an extension compression type fracture, where the ALL is damaged in the front from the tension component, and then there's compression in the back in the posterior ligamentous complex and the spinous processes.
It takes a lot of force to tear the ALL. It's a really, really strong ligament.
Mm-hmm. Yeah. So here's another great picture. Just going through the different mechanisms and of injury.
These are probably just pure distraction, pure shear.
Yeah, the shear one's interesting. It's kind of like almost like a teardrop type of mechanism. Mm-hmm. So this is a great picture I found. It's a 3-column system originally described by Denis. Actually, I think he modified it. I think there was the 2-column system, and then he modified it into the 3-column system.
I think you have it somewhere here.
Yeah, a little bit further back, we talk about it.
What was it? Watson Jones.
Watson Jones originally described, the 2-column. Mm-hmm. That's correct, yep. So with this one, just going through the different portions, it's very important when you're talking about classifying these fractures and just understanding the mechanism of how these occur. In the anterior column, you have the ALL, and you were just talking about how strong it normally is. So it takes a lot of energy to rip through that. You got the anterior 2/3 of the body of the vertebra and the disc. Moving on to the middle column, you have the posterior ligamentous, the longitudinal ligament, and then you have the posterior third of the body and the disc. And then moving into the posterior column, you have the pedicles, the lamina, the facets, the ligamentum flavum, spinous processes, and the posterior ligamentous complex that's kind of encapsulating and keeping that all together.
And these columns these are man-made ways to think.
Right.
So like if you think about it, when it's just the anterior column, mm-hmm. What is it usually when you see that?
It's just like vertebral compression fracture.
Yeah,
like
which is what's like a typical case that you see?
Like 85, 90-year-old woman, something like that.
Osteoporotic lady. Yeah. She just falls a little bit. Mm-hmm. Low energy injury.
Right.
But to see the middle column, it can be 85, right? But it's usually bigger fall, maybe more car accidents. And when all three, it's usually very bad injuries. So I think what happens is over time, people saw all these injuries and they just corresponding the columns and to make a way to think about it.
Right. And then this is just a little bit more in-depth look at the posterior ligamentous complex and what comprises of it and how we think about it. You know, you're looking at the supraspinous ligament over the supraspinous processes in the back, and you have the inner spinous ligament in between. Then you got the ligamentum flavum as you kind of move more centrally, and even the facet capsule, you know, makes up this complex. So a lot of times when you see these traumas and you get the MRIs to rule out that posterior ligamentous complex injury, you're looking at all these structures. So here's some of the imaging that you would typically get. You know, a patient comes in the emergency room, they had some sort of injury, some sort of trauma, car accident, that kind of thing. You would want to get a CT scan at first, you know, just to look at all the bony structures. This is the best imaging modality to look at the bony anatomy and see if there's any injury there. If you're not sure about,
and it's fast.
Yeah.
In the ER, everybody gets a CAT scan.
True. Yeah. If you're, you know, concerned about something else going on, something more soft tissue, something neurological, then you want to move into getting the MRI. You know, that's a little bit challenging at some hospitals. Sometimes they really fight you for those, but, you know, you just got to tell them you're worried about like a spinal cord injury or some sort of cauda equina type thing. You know, those are usually buzzwords that you can get them to do the MRI scan.
Not as much as it used to be. It used to be really difficult. Yeah. But now they have the what's it called? The spinal cord, what's it called?
The cord compression.
Cord compression study.
Yeah. The quality on those aren't the best, you know, but yeah, they will kind of show you what you need to see. Yeah, so, you know, with your MRIs, it's way better for looking at evaluating the cord, fecal sac compression, anything like that, any cord edema or hemorrhage. And I think most importantly is just looking at that posterior ligamentous complex. You know, if you get that flexion distraction injury, then you know in the back, if that's injured, then this can be an unstable, you know, injury and probably needs something like some sort of surgical fixation, you know, depending on, we're going to go into the TLIX scoring system later in this talk and kind of goes with your management options.
Yeah, but that's a perfect list. You make sure there's no blood in the spinal canal.
Yeah.
If the cord is edema, that's important to know. This is all good in the ligamental complex.
So this is talking a little bit more about burst fractures in particular. You know, this involves the anterior in the middle column. You know, usually there's some sort of bony retropulsion. This is what separates it from a pure vertebral compression or wedge fractures, as sometimes they're called. That's just an anterior column injury, and this one has both. It's usually, you know, an axial loading and a flexion component to this injury. Commonly, you know, this is in the thoracolumbar spine. And it's important to kind of look at the entire spine because 20% of the times you're going to see a concomitant spine fracture somewhere else, you know, in the body. So
let me tell you one more thing is you didn't go over this, but the question is you're on call and a patient comes through and they have a CAT scan and the ER doc always says, this is the last time I looked this up, so I don't know if the literature has changed, but the ER doc says, do we need an MRI? So I usually break it down three things. There's physical exam, there's CAT scan, and there's MRI. So if you have a patient who has zero physical exam, like in a coma, intubated, but you have a normal CAT scan, normal MRI, you're good. And you need basically 2 out of the 3. So the physical exam, either a normal CAT scan and no MRI, or you see what I mean? So if you have a normal exam, you're more comfortable. There's nothing wrong with the spine.
You need at least 2 of the 3. To kind of feel comfortable with it.
Right.
That's what you're saying. Yeah, so with instability, you're worried about instability with any of these anterior middle column injuries. You know, something that you would see on x-rays, like if you have widened pedicles, that one area, you have that loss of the height of the vertebral body. You can get what's called a bony chance fracture, where it's kind of like on a 3-column injury. And if you look at the inner spinous in the back, if it's widened at all, you got to be very suspicious of some sort of bony chance injury or just a soft tissue chance.
Soft tissue chance, yeah. And sometimes a bony chance, you don't see anything. It's just it fractured, and then it goes back.
Mm-hmm.
So sometimes it can be, you don't see it on the x-ray, but you see it on the CAT scan.
Right. So here's CT imaging kind of showing that flexion distraction type of mechanism. In the front, you see it's kind of wedged, compressed. In the back, you see the spinous processes are very widened. So this would definitely be like a bony chance fracture.
Looks like everything is torn here.
Mm-hmm.
But the front is bony, but the back is all ligament.
Mm-hmm.
So this is a lot worse than, you can also have a chance like right through here.
Right
through here, and then to the posterior spinous lamina, through the pedicle,
mm-hmm.
and then through the bone. And that's more likely to heal because it's all bony opposition.
Right.
But this is a lot less likely to heal because it's through the soft tissues.
Yeah. Other than that, through our residency, it's just soft tissue stuff is a lot harder to heal than,
mm-hmm.
bony stuff. Yeah.
Mm-hmm.
Here's another MRI. This is showing a T12 vertebral body fracture. If you look, there's edema there. There's a increase in signal. And also, if you look, there's also a T11, like a microtrabecular type of fracture too. There's a little edema there as well. And if you look posteriorly, you see posteriorly you see the edema there in the posterior ligamentous complex there as well.
See a little white thing right there?
Yeah.
Where it should be ligament?
Mm-hmm. So it's all edema going on in there. So there's a complete rupture of that T11-12 ligamentum flavum, the interspinous ligament, and the supraspinous ligaments there.
I look a lot in the back here. You see this black line connecting the posterior spinous process to posterior spinous process?
Uh-huh.
I look at that a lot right there. This little black line.
Yeah, they just follow it down and then
mm-hmm. And then you see right there, it's clearly ruptured.
Mm-hmm.
So this is a good case, but frequently you can't tell. It's like the MRI is not good, the patient's moving, but this is a nice case.
Yeah, sometimes it's equivocal, then
mm-hmm.
What do I do?
Right. Frequently it's equivocal.
Yeah. So here we have a question. 32-year-old man presents to the ER sustaining an L1 burst fracture and a fall. So you do the neurologic exam. They're in Asia E. I think of it as E for excellent. They're 5 out of 5, no real issues going on. MRI shows a mild vertebral retropulsion of 10% of the central canal stenosis and no evidence of injury to the posterior ligamentous complex. So which of the following is true regarding surgical decompression and fixation?
So this case is just barely a burst, right? Just minimal central stenosis, nothing posteriorly.
Nothing neurological.
So it's kind of like the least burst you can get.
Right. So think about all these things, do you do surgery, or if you do surgery, are they going to return to work earlier? Are they going to have any decreased pain scores? Are they going to have any increased complications? How are they going to do with their scores on the SF-36? You're just thinking, basically, if I'm going to do surgery on this patient, what's going to happen? Is it really going to help them? Or if I just brace them, So they quote this article here for this question, operative compared to non-operative treatment of TL burst fractures without neurologic deficit. So I think that's a very important thing, is that there's no neurologic deficit. What are you really trying to help the patient with? In this scenario, they're saying you should just brace them, because if you do surgery, you have all the complications that come with surgery. You can get infections, you can get seromas, you can get some type of hematoma, compressing things. Like, there's all these things that can happen when you do surgery. So
this article was in 2003. This was a backlash to pedicle screws, because when pedicle screws became in the thoracic spine, became very popular, like 97, 98, 99, around that time. Before that, it was hooks. So all the trauma surgeons were treating everybody with 4 screws above, 4 screws below for every burst fracture. And this article this is not the only article. There are many articles to this topic, but that's when it started, that people were just studying it, no surgery, because like everything in practice, there's a pendulum, and the pendulum went way too far. Everyone was getting surgery. Mm-hmm. So that kind of pushed back the field around that time, 2003, 2004.
Yeah. So moving on to classifications of these type of fractures and injuries. So like we were saying before, Watson Jones in 1938 first described 3 injury characteristics. There's a simple wedge fracture, there's a comminuted fracture, and then there are fracture dislocations. So they commonly created this system for medical decision making, and they used it for reduction techniques. Kelly Whitesides later on modified this, and also Denis, for anatomic classification of the 3 columns. So Denis distinguished the middle column. This is what differentiated compression fractures of just the anterior column versus burst fracture, which involves the anterior middle column. Anatomical classifications didn't really address the importance of the posterior ligamentous complex or guide decision making. So these are more important historically for just nomenclature. So AO did their classification, looking at CT scan, 3D recons. The type A, is usually a compression type. The type B is a distraction type, and then type C is more of a rotational type of injury there. So this is the one that I think was a really landmark paper. This was done by Vaccaro and Patel and their colleagues over at Rothman in 2010. And this really guided surgical management or non-operative management. They just broke it down into a scoring system. You looked at the morphology of the fracture. If it's a compression, you get 1 point. If it's a burst, you get 1 point. But then if there's any translational, rotational component to it, then just 3 points there. Distraction, you get 4 points. Any neurologic type stuff. If they're intact, nerve root injury, cord, conus medullaris type stuff, cauda equina. And then another really big point is the posterior ligamentous complex. Is it intact? Is it equivocal? Is it injured? That's when you really need that MRI scan to look at that. And what they basically said is if you have 4 points or below, non-operative usually, the gray zone is right at the 4 point mark. If they just happen to fall at the 4 point mark, you could really go either way, just depending on your experience with your patients and how you think they're going to do. If it's a younger guy or if it's a older lady, then, that might really guide your decision making one way or the other. But anything over 4 is almost always surgical. And, their paper found, 95 to 96% validity when they had multiple surgeons do the scoring system, and it was pretty reliable.
I want to add one more thing. Is this,
Sure.
This is, if you compare this to all the other ones, this is the first classification system that brings into neurological status.
Right.
All the other ones are just X-rays.
Right.
So, and the way I think about it is that if a patient has an injury, even like a femur fracture, if you have a femur fracture with a neurological injury, that's a bigger injury, a bigger car accident, higher energy injury than no neurological injury.
Right.
So same thing in the spine. So if the injury caused neurological injury, the force of the injury's got to have been much higher, and it's more important. Just like if you have a nerve out in the leg, if you want that nerve to recover, it's better to treat it operatively to fix it, so so there's no motion across. Same thing in the spine.
Yeah, going back to the AO principles and stability and everything like that.
Yeah, same thing.
Mm-hmm. So here's another question. 32-year-old male goes to the ER following a motor vehicle accident. Radiograph is in figure A. You got your sagittal, axial, CT scans in B and C. So what is most likely the mode of failure in the posterior spinal column? Looking at your x-rays here, you see that comminuted, it's like through the whole body there. It's wedged in the front. In the back, I can't see much. So
look at this line right here.
Oh yeah.
So looks like it's going a little bit posterior.
Yeah, it's definitely a little retrolisthesis there. So you're thinking instability. You're thinking something's going on there. On the CT scan, you see a huge bony retropulsion, and there's that anterior fleck of the bone as well. And then if you really scrutinize, there's a fracture line right there through the posterior spinous process. Axial cut, you kind of see it's through the whole body, indicating at least an anterior middle column just on that one slice there. But if you look at this one in combination, then it's a 3-column injury. So with here, they're asking you what specifically is happening in the back. What is causing that failure? So the answer to this one would be tension. So the all the ligaments in the back are, you know, a tension band for the spine. So when that fails under tension usually. But if this question was, you know, redirected towards the front, then you would be saying compression, which is probably where some of the people, they weren't really reading the question too carefully.
It's a tricky little question. Also, they didn't put distraction; they put tension. So that kind of throws some people off too.
Yeah, because you know, buzzword is distraction, right? Yeah. So you're looking for distraction. Like, where is it? Where is it? But then you see compression, you're like, oh, maybe. You know, if you're like on an exam doing your
and you're tired. Yeah, that's a clever question.
They do a lot of these and try and trick you. Mm-hmm. So this one, I'm going to talk about the chance fractures. This is your 3-column injury. You know, it could be bony, it could be ligamentous, like a soft tissue chance. Usually it's the same thing. You have anterior compression, but then the back, you know, in the middle column and the posterior column, you have that tension or distraction injury. Something to keep in mind is when you see a patient in the ER, they come in, you see that seatbelt sign right here. All that bruising around the abdomen, you got to think about GI injuries. They might have some sort of visceral injury. They should really get, you know, scanned and everything, make sure that nothing's going on there. You want to get your standard x-rays and MRI to rule out any type of posterior ligamentous injury. So here's a question. 12-year-old boy, you know, brought to the ER emergently following a motor vehicle accident. You know, he was restrained in the back seat with a lap boat. Physical exam shows bruising noted across his abdomen, like we were just talking about. Lateral radiographs are shown in figure B, which is going to be on the next slide. But which of the following injuries are most frequently associated with this injury pattern? So you got that seatbelt sign there. And here you see like a very like focal kyphosis, you know, you see some wedging of that vertebral body there. So you got to be very suspicious of this.
In your residency, did you ever see any lap belt injuries like that?
Yeah, a few times, for sure, yeah. You know, so sometimes they would have...
But don't the kids have shoulder straps now?
A lot of times, yeah. I think that's a requirement, yeah.
Because it's not as common. So when I was a resident, the kids either nothing happened to them or they died because they flew out of the car. And when I was in residency, a common injury was spinal cord injury without radiographic abnormality because the kids were ejected. And then it was then there were lap belts, and then we had a lot of these lap belt injuries. But now most of the kids have 4-point restraints or 3-point restraints. So because of the seatbelt laws, there's a lot of less of these cases.
Yeah, I probably only saw 1 or 2 residents.
Yeah, because of the seatbelt laws, they're uncommon. So, are you from New York?
Yeah.
The first seatbelt law was in New York.
Oh, you know. Yeah. So yeah, like I didn't see too much just because like we were all under the impression that traffic is so bad in New York that no one could really usually go fast enough for anything like this to happen.
No, seatbelt laws. Seatbelt laws. New York led the nation in seatbelt laws.
Right. So yeah, going back to this question, you really want to worry about some sort of abdominal visceral injury, you know, like a colonic rupture. Cardiac tamponade is not likely in this scenario. It's a little too high up. Pulmonary contusion, I mean, I guess it could happen, but not as likely.
More likely for a thoracic fracture.
Yeah. Bladder rupture, I mean, they don't think that's as likely as a colonic rupture. And acute cholecystitis is just, it wouldn't be caused by trauma like this.
But five people said cholecystitis.
Right. Yeah, so treatment, you know, what do you do for these people? You going back to the TLIX scoring system, you know, that kind of makes it easier for you to decide as a clinician, you know. Below 4, you want to just brace them non-op, especially if they're neuro intact, you know, nothing going on there. What are you going to do surgically? So you want to do like a TLSO or an LSO bracing, but it's really important to watch these patients. Sometimes they don't tolerate the bracing well. Sometimes they can decompensate. You know, you can't just say, you know, brace and then follow up with me in 6 weeks. You know, that'd be probably too long of a period. You might want to see.
If you put someone in brace, how do you follow up with them?
I'd probably say every 2 weeks, maybe something like that. Maybe 1 week at first, and then maybe if they're doing okay, gradually.
That's a good idea. So I would get an X-ray before they leave, see if they're wearing it.
Yeah.
And then 1 week is a good idea because some people just don't wear it or they don't know how to wear it.
Right.
make sure they're wearing it. Yeah, and then see them frequently.
Get X-rays at every office appointment too, just to make sure nothing's changing with the fracture. It's not moving on you, translating or anything like that.
And I tell them, I'm having you come back frequently so I can watch the fracture and make sure it doesn't shift, just in case if it does shift, you may need surgery, so that they know how important the brace is.
Right.
And so it's not a surprise if it happens.
Mm-hmm. So with operative fixation for these type of patients, you're thinking neurodeficits, you're thinking unstable fractures. When you have that posterior ligamentous complex disrupted, you have a really bad focal kyphosis. That gets worse over time. Like you were just saying, you see them in the office and then they keep getting worse. Then you really got to think surgical indications here. They have lamina fractures. Sometimes with lamina fractures, you got to be really careful, because when you go in there surgically, you're going to see a bunch of nerve roots come popping out at you, because a lot of times that lamina fracture can actually cause a dural tear. And like we were saying before, TLIX scoring, if you score them and they're above 4, then they're almost always operative. So, you just go through all of the different surgical options. Are you just going to fuse them posteriorly? Do you need to do a decompression? Is there any type of stenosis there caused from the injury? Do you need to do some sort of anterior decompression stabilization? These are all things that kind of just is more specific to the patient's injury, and, going from there. So here's a good chart I found in the World Journal of Radiology. This kind of just hones in on that intact posterior ligamentous complex or disrupted, and the surgical approach you can use when these fit that criteria. If they're intact, or if they have a nerve root injury, if they have an intact posterior ligamentous complex, you want to go posterior. If it's disrupted, you want to stay posterior. But if they have an incomplete cord injury, you actually want to go anterior. If it's if it's disrupted, you can do a combined approach. With complete cord injury, you can really do both, either way.
Where did you get this from?
The World Journal of Radiology.
Okay.
Yeah.
On burst fractures?
Yeah. And they were kind of looking at cervical fractures as well. And, it's just, it wasn't just specific to thoracolumbar. So this kind of included some sort of cervical stuff. Mm-hmm. So here's some of the cases in that TLIX article. And I think these are very good. And they kind of go through the whole thing. So a 63-year-old male, 15-foot fall. He has back pain, but he's neurovascularly intact, 5 out of 5 motors, sensations intact to light touch. There's no posterior tenderness or step off, and he has a good rectal tone. So, the imaging shown there, what would you score it with TLIX scoring, that kind of thing, and the treatment, just going through the whole case. Let's see here. Oh, sorry. So, looking at the morphology there, it's a burst fracture. Looking at that first figure A, they're neuro intact in the question stem. Their posterior ligamentous complex is intact. If you look at the MRI there, I don't see any edema there in the back at all. Mm-hmm. So the total severity score would be a 2. So in this case, I would treat this patient non-operatively.
Let me see the. Is that right?
Mm-hmm, yeah.
So you get 4 if you're distracted.
Mm-hmm.
So you get a lot of points. You get 3 points if the posterior complex is injured.
Yeah.
That's a lot of points. That almost puts you to surgery.
Right.
So cauda equina, yeah. And it makes sense. The incomplete spinal injury is the worst injury because you can actually help those people with surgery. Yeah, that makes sense. Translational, rotational patients are the worst. Okay.
Mm-hmm. Yeah, so this patient,
sorry.
This one, yeah. So, this patient, they're neuro intact. It's just a simple burst with minimal retroculsion. There's no real stenosis that's causing his pain or anything like that. And, what are you going to do?
And no kyphosis at all, no deformity.
Exactly. Mm-hmm. So for this patient, I would brace him, just do close follow-up and put him in the TLSO. Mm-hmm. So case number 2, you have a 28-year-old male, ski accident, 30-foot fall. So they do have back pain and they have
they have pain to the legs bilaterally. So on the
what's NT, nerve retention signs?
Yeah, yeah. So physical exam, there are 2 and 3 out of 5 muscle groups, all in the lower extremities. So you have that neurologic compromise there. They have the diminished rectal tone. Their sensation is in tactile touch, but so imaging here, figure A, you got that CT scan. So burst, right? So that's 2. They're incomplete cord injury, so that gives them a 3.
Let's go back to the
Oh yeah, the chart. Yeah.
So let's see, morphology. It's a burst.
Mm-hmm. So that's confusing.
He's not distracted.
There. Yeah, it's confusing. It's because that's +1.
Oh, I see. So he gets 2 there.
Yeah, exactly. He gets 2 there.
So he's incomplete, right?
Yeah.
Well, he's not caught equina.
No.
He does it. His anal tone is abnormal.
No. Well, he says he does feel sensation.
He does. So he's got 2 for the burst, 3 for the incomplete injury. So he's 5. And didn't you say that posteriorly it's injured? Was there an error?
It's indeterminate. So looking at it, if you're not really sure, that's not. I don't see like all the edema. It's not as clear picture. I don't see frank edema there. So if it's indeterminate and you see a little something, you give that 2 points.
So he's 7.
7, yeah. So this guy would need surgery.
Well, he's got a deficit, and also he's got this huge fragment in the front.
Right.
So I think you have to go anterior on this guy to remove this fragment to ensure that his deficit goes away.
Yeah, I agree. And then there's that lamina fracture there too. So you got
to be careful. You got to be careful.
Yeah. So this is the surgical treatment.
This was at L2?
Yeah, I believe so.
Yeah, there's the diaphragm. It's here. That's probably 1. Yeah, it's 2.
Yeah. So like you said, they went anterior. They had to do the whole corpectomy, put in a corpectomy cage. Looks like an expandable one there. Yeah.
I mean, I don't do much trauma anymore, but I used to just put a piece of femur with a plate, and I used to get extra fixation with the plate.
I've seen that. Yeah.
And sometimes that's it. I don't do any more fixation.
Nothing posteriorly, just that.
Yeah, I've done that in many cases, and it worked well. But the posterior, if you do the anterior decompression with the cage and a plate, and then posterior, you can just put posterior screws without decompressing. That way you stay away from that lamina.
Yeah. Looks like a cross link there too, maybe. Hard to see.
Yeah, there's a cross link there, yeah. That makes it even stronger. Yeah. These guys are great when you're in the thoracic spine and you cut the nerve root, and you can avoid the anterior chest trauma. So you just cut the nerve root, and then you just put that laterally to avoid the thoracotomy, and then you distract it. You don't need the plate. That's what the best thing about these implants are for.
Yeah, it's just they're all sensory kind of up there, right? With the nerve root, so.
You can cut T12 and up. So that's the best indication for these distracting anterior struts.
Yeah.
Otherwise, if you're already going to do a thoracotomy, me personally, I would rather just put a piece of femur or whatever you want, cage, and a plate. That way you have more fixation. Just ideas.
Yeah.
Is that it?
One more.
Okay.
So this is a third case, 18-year-old female, rollover MVA, neurovascular intact, 5x5 strength. There is a tender gap in her thoracic lumbar region when you're palpating her.
So we know she's a 3 already.
Yeah, exactly. Because that, there's probably a step off there, so imaging here, an A, you see that T12 wedge, that anterior compression, and in the back, if you really scrutinize, you see a fracture line right there in the spinous process, and this is widened, obviously. Here in the figure B, see a very comminuted vertebral body. It's a strange cut here, but there might be something there as well. And then C, on the MRI, you kind of see all the edema, all the hyperintensity. You see that posterior ligamentous complex injury, and they're in the back. So yeah, like you said, that's already a 3, right? So, but then she's neuro intact. So that gets a grade of 0. And then the posterior ligamentous complex is a 3, and the morphology is a 3 because there's a translation injury there.
She's a 7.
So the total score is 6.
6. Okay.
Yeah. So, it puts her over the 4, so she needs surgery. So this is what they opted for there.
Okay, they went all posterior.
Yeah, all posterior long construct.
Mm-hmm. The other thing you could do is, so this goes down to 2. I mean, this is a safe, good way to go.
Mm-hmm.
The other thing I was thinking is it'd be more trauma, but you could take the T12 nerve root and put a cage at T12.
Yeah.
And then the standard approach used to be remove the T10 rib, take out that 12. But you don't have to go anterior because you don't have to remove all this.
Yeah. The only thing I'd be worried about is the MRI there. It looks like it's kind of draped over it, so it's like.
What do you mean? So by going posterior only?
Yeah.
No, you get the alignment on the table.
Yeah. Okay.
So when you lay,
reduces.
yeah, I mean it's not perfectly straight, but you can get the alignment on the table. That'll come right back. But the question in this case is, will this collapse? So, and they have short screws here.
Yeah.
The question is, will it collapse over time? And you brace. I'd probably brace this person too. But I guess you don't really have to go. You probably don't need anterior support here. It's not too complicated.
Mm-hmm.
But if you did that, like that other guy, that big fragment here and in neural deficit, then you have to go anteriorly and remove the rib and make sure you get all these fragments out.
Mm-hmm.
But it's good to think about everything.
Yeah.
And what your options are. But the posterior is the easiest, safest probably.
Yeah. And traditionally, everyone always says you got to go like 3 above and 2 below, right, with the pedicle screws. But I think people are moving more, less aggressively now, and maybe just 1 above and 1 below. I've seen that sometimes too.
With nothing anterior?
Yeah, depending on.
Well, it's okay. So it started. So pedicle screws started in like 90, 96, 97, 98. Trauma surgeons were putting them in. Initially in Europe,
Mm-hmm.
they were doing, there's all this history, but I don't know if you care about this, but I'll just tell you how it evolved.
Oh, yeah.
Initially in Europe, they were putting just like 1 level above, 1 level below, that's it, and fix it. And they failed frequently. So then many people were going anterior first, put in a cage to get anterior column support, and then just screws above and below. But then you do an anterior procedure, which is a lot of surgery.
Yeah.
So then the next step would be 2 above, 2 below, or 2 above, 1 below, and 1 below probably is not enough, but you want to save levels.
Yeah.
Because you're supposed to have motion in the lumbar spine. And then those kind of failed, and then there's 2 above, 2 below. So that's how it kind of evolved.
Gotcha. Yeah.
So it could be that people are getting better with pedicle screws, maybe.
Yeah.
And but you could also do 1 above, 1 below, and just brace the patient. And you get your alignment, and then hope if it's a really skinny patient, a compliant patient, that'll work. So just, things to think about.
Yeah.
Or if a kid, like an 18-year-old is basically a kid. You get a skinny kid, you can go 1 above, 1 below, put them in a brace.
Mm-hmm.
I mean, that's reasonable. Is that all you got?
Yeah, that was all the cases.
Anything else?
No, I think that was a good talk.
All right, man.
Learned a lot from this.
Thank you. Thanks for coming. Let me just turn